Doktor boleh doktor buat full screen tak?
Dia tak full screen
Tak full screen. Slide tu nampak kecil sikit.
Oh ya ke? Sekejap Oh, sekejap, hold on. Tak nampak full screen Alamak, kalau tak aku tak boleh nampak aku punya presentation. Okay lah, tak apalah
Okay, I think this one much better daripada tadi.
Okay, but there are some parts where I have to minimize sikit because saya punya komputer ni tak tahulah saya tak pandai sangat ke apa kan. Okay, tak apalah, it's okay.
Okay, kita mula ya doktor?
Alright, sure, thank you.
Okay. Assalamualaikum warahmatullahi wabarakatuh and a very good morning to everyone. Let's begin our CME today with Furqan Al-Fatiha. Welcome to our CME number 8 for today. Before we start our CME today, I would like to remind the participant to turn your microphone off during the talk. And don't forget to register in iAttend for attendance. Please be reminded that the attendance will be given in the chat box after 15 minutes of the talks. For medical practitioner, kindly fill in the Google form for CPD point. The link will be given in the chat box later. Please be informed that this CME is live streamed via Sasmat YouTube channel. If you have any question, you can type in a chat box or you can interact with the speaker during the Q&A session. Without further ado, I would like to invite our speaker for today, Dr. Wan Alina Khadijah binti Wani Ahmad Mustafa from Department of Pathology and Laboratory Medicine, Sultan Ahmad Shah Medical Center, Sasmet at IIUM, to give her talk with the title, Why Give Two When One Will Do? Tafadhal, Doctor.
Assalamualaikum warahmatullahi wabarakatuh. Can all of you hear my voice?
Yes, Doctor, loud and clear.
Okay, thank you very much, Chairperson, for the kind introduction. My name is Dr. Wan Alina Khadijah. I'm from Pathology Department and I'll be presenting my CME today titled Why Give Two When One Will Do? Okay, Bismillahirrahmanirrahim, let's start. Before I begin, allow me to introduce the panel of experts, the ladies behind the hematological reports, our hematopathologist, none other, Associate Prof. Dr. Nur Lelawati, our HOD of Pathology, Assistant Prof. Dr. Damira Naziha, as well as allow me to introduce the latest addition, Dr. Sarah Abdul Halim, to the Pathology Department. Okay. So at the end of my session, if there are any questions, you can ask them directly through the chat box or at the end, just by opening your mic at the end of my session. Okay. So this is the outline of my presentation. I'll be starting with scenarios, followed by what is PBM and why we have to implement PBM. And also I'll be touching a bit about restrictive versus liberal transfusion strategies. Okay, my whole presentation consists of about 30 slides in total. So I hope to be able to present it in a more concise way. So we start with the first scenario. A 40-year-old Malay gentleman with underlying DM and hypertension was admitted for left foot DFU and underwent extensive wound debridement of left foot. The pre-op HP was 9 and the post-op day 1 revealed HP of 8.3 grams per deciliter. Patient was otherwise asymptomatic of anemia. However, examination of the left foot showed infected wound. The medical officer in charge requested for 1 pint of Paxil for wound healing purposes. I think from this is a very common scenario. I think most of us have requested for blood for wound healing purposes before this. It was the norm before, but now that we know, there are some journals, for example, this one, perioperative blood transfusion and delayed wound healing after hip surgery. It showed that they compared the two groups. The first group, which did not have any transfusion, as you can see in the black graphs over here, and another group that received transfusion, as highlighted in the white graph. Okay, they compared these two groups and they found that 31% of those patients who were transfused had wound disturbance versus 18% of the non-transfused group who did not have wound disturbance. Sorry, 18% of the non-transfused group who had wound disturbance. Okay, so you can see the difference in percentage, 31 versus 18%. There's another journal. From this journal, it was found that restrictive transfusion practices reduce transfusion and decrease infections without increasing adverse outcomes in major orthopedic surgeries. We move on to the second scenario. A 47-year-old Malay woman was admitted for myomectomy for multiple leiomyomas. During the pre-op assessment, 2 weeks prior to admission, the HB level was 8. Patient was then started on oral iron, and 2 weeks later, on admission, the repeated HB was 8.5. So I would like to highlight from this scenario that whether 2 weeks for pre-op assessment, is it enough? Okay, and whether the treatment the modality of oral iron is adequate for this patient. Although there was an increment of the HB level, but it was only of 0.5 grams per deciliter. Okay, so from this journal, it is stated that the HB level should be measured at least 4 to 8 weeks prior to an elective surgery, as recommended by the European Society of Anesthesiology. The reason behind this is so that ample time can be given to the patient who had been started on treatment to see the result of the treatment that was started. Okay, and from this another study, it was a comparative study to evaluate whether oral iron versus intravenous iron, and they found that the number of participants who reached the target HB at 4 weeks was only 82% in oral iron. However, it's higher in the IV iron group, which is 96%. So you can see that if you start the patient on IV iron, the target HB can be achieved higher through IV iron. So now we get to what is PBM. Okay, so PBM is an evidence-based multidisciplinary approach aimed at optimizing the care of patients who might need transfusion. It puts the patient at the heart of decisions made around blood transfusion, promoting appropriate use of blood and blood components and the timely use of alternatives where available. So if I cannot stress more, it's a multidisciplinary approach based on evidence. And here we go on the concepts of PBM. Okay, it consists of 3 pillars, mainly to optimize erythropoiesis, followed by to minimize blood loss, and to harness and optimize physiological reserve of anemia. And each of these pillars of PBM is further divided into pre-operative, intraoperative, and post-operative. Again, this might be a busy slide, but my most important slide. The PBM consists of 3 pillars: Pillar 1, Pillar 2, and Pillar 3. As for the Pillar 1 is to optimize the RBC mass, and Pillar 2 is to minimize the blood loss, and Pillar 3 to manage the anemia. I'm sorry if I have to minimize my view for a while. Okay, all right, because I need to elaborate further on this table. Okay, we go, let's zoom in to the pre-operative part first. Okay, pre-operatively, it is important to investigate and treat the underlying anemia. For example, if the patient has iron deficiency or vitamin B12 or folate deficiency, it is important to treat and to address those issues first. And also do not hesitate to start the patient on erythropoietin for patients with chronic anemia or anemia of inflammation. Do always to remember to supplement with iron to avoid functional iron deficiency in cases where there is higher rate of erythropoiesis. And also to cease medications that can increase bleeding, for example, antithrombotics. To also address the bleeding risk, for example, if the patient has underlying ITP and plan for surgery, maybe the primary team can start the patient on glucocorticoids or IVIG to increase the platelet count prior to the surgery. And also to reduce blood taking whenever possible. Okay, in terms of surgically, it is always advisable to rehearse the procedure post-op and always opt for less invasive techniques if they are, and to re-stratify the patients with low anemia tolerance, for example, patients with heart failure. Okay, now we move on to intraoperatively. Again, if there is an option for less invasive procedure, do opt for that. And the use of electrocautery devices and hemostatic agents may be beneficial to secure the small bleeders, and also to practice restrictive transfusion if there is bleeding less than 500 mils. Okay. However, if there is massive bleeding, do not hesitate for fluid replacement and transfusion if needed. Although be wary to avoid large volumes of crystalloid, as this may cause dilutional anemia and coagulopathy. And to keep the patient normothermic, because hypothermia can cause coagulopathy due to impairment of the platelet aggregation and reduce the enzyme activity in coagulation cascade. Do use blood warmers, warming blankets, and saline warmers where available. As for blood conservation techniques, there are some techniques that are being practiced in other centers, such as cell salvage and acute normal volumic hemodilation in selected cases. As for post-op, it is crucial to monitor the patients for persistent bleeding and to minimize blood taking, again, to minimize whenever possible, and to initiate treatment early and to assess the need for re-exploration if needed. Okay. So this is a bit hard, a bit handful to digest, but it is my most important slide. Okay. I would like to further zoom into preoperative anemia, as I believe planning for an elective surgery is very crucial. So this part is a huge chunk to prepare before the operation, because this can significantly reduce the risk of negative clinical outcomes post-operatively. Okay, so preoperative anemia is often undiagnosed and is seen up to 75% of the patients, depending on the age and comorbidity. Although it's mild, it can be a marker for disease and associated with increased perioperative mortality and morbidity. So anemia, whenever you see anemia, there's always a reason for it, and you have to always investigate why the patient is anemic. And it is also associated with 2 to 6-fold increase in perioperative transfusion and post-operative anemia. It should be diagnosed at least 4 weeks ahead of surgery to allow time for correction of the hemoglobin level. So now we know if we detect the anemia, how do we treat the anemia? The aim is to raise the hemoglobin concentration before the surgery, and the treatment should be directed against the cause of the anemia. And iron deficiency and in functional iron deficiency, hemoglobin can be raised with iron alone or in combination with EPOs. Iron can be administered orally, which is cheap, but takes 2 to 3 months to work. So like our second scenario just now, 2 weeks with oral iron is not enough time for the for the correction of HB prior to the surgery. And IV iron is more, although IV iron is more expensive, but it may increase hemoglobin levels in a much faster rate within 2 to 4 weeks. So now we go, why do we have to implement PBM? Okay, firstly, it's because of the high incidence of anemia. Takkan all the anemic patients we see, we want to transfuse, am I right? Because there are so many patients out there who are anemic. And anemia, who are anemic, and there are other modalities that we can tackle the anemia besides transfusion. Okay, secondly, because of morbidity and mortality that is associated with transfusion. And then lastly, because of the challenges of the product supply, and also it is costly. From this journal, basically it just highlights the 3 things I've mentioned earlier. Again, it causes transfusion associated with morbidity and mortality. It is costly and relative shortage of resources. And preoperative anemia is most commonly caused by iron deficiency. I cannot stress more regarding the shortage of the resource. I think we all felt it during 2020 when COVID hit us. That time, the supply was really short because blood donations cannot be conducted, and we had to be really stringent and with the sources that we have. Okay, let's focus on high incidence of anemia. Sorry. Okay, did you know that about 25% of the global population are anemic? Okay, about 25%, that's a lot. And 1/3 of the world's population is anemic, and half of the cases are due to iron deficiency anemia. See, which is very preventable and treatable. Next, we go on to morbidity and mortality of transfusion. From this journal, transfusion of RBC, FFP, and platelet is associated with mortality and infection after cardiac surgery in dose-dependent manner. They found that the transfusion of any blood type was associated with higher rates of mortality, 2% versus 0.18%, and infection rate of 13.3% versus 4.8% of any blood types. Okay, again, why we have to implement PBM is because they noted that from this study, with PBM, there is 6% absolute risk reduction for transfusion, and when there is, and also there is 22% reduced rate of transfusion. With the implementation of PBM, it reduces transfusion and improves clinical outcomes. Another one from this journal is also implemented. It is also stated that with the implementation of PBM, it is non-inferior in terms of patient safety, and it is more cost-effective. Again, implementation of PBM results in a reduction in perioperative transfusion in cardiac surgery and reduction in hospital length of stay, which also in terms of costs, there's a reduction in costs, okay, when there is reduction in hospital stay. Next, we go to resource supply and cost effectiveness. By applying the 3 aspects of PBM, for example, in this study, they did implement iron supplementation, cell salvage, and tranexamic acid. It is associated with reduced transfusion rate and length of stay. And they found that the overall benefit of PBM saves 21.60 euros per patient. And if you look at this journal, they found that in year 1991, the cost to produce a single unit of bag only costed $350. But after 10 years, in the year 2000, the cost increased to $780. The cost per unit doubled in approximately 10 years. However, in Malaysia, we're still quite lucky because the the approximate value for per unit is only 280 ringgit for one whole blood bag. But this is only speaking in terms of the production of the blood itself. It does not include the cost for the acquisition of the blood, for the nursing part, and also for the laboratory part of the cost. Okay. And from this micro costing study, they tried to look further into the laboratory inputs as well as the nursing inputs, just to calculate the annual cost of blood administration, excluding the price of the blood bag itself. Okay, just for the blood administration itself, annual cost exceeds $175 million. Okay, now we move on to restrictive versus liberal transfusion strategy. So this is a landmark trial titled Lower versus Higher Hemoglobin Threshold for Transfusion in Septic Shock. Okay, in short, they call it TRIS. And from this trial, they found that patients with septic shock who underwent transfusion at a HB threshold of 7 had similar mortality at 90 days, but used 50% fewer units of blood compared with those who underwent transfusion at HB threshold of 9 grams per deciliter. So whether you give 7, you use the threshold level of 7 or 9, no difference was seen at 90 days, okay? In patients who are septic, who have septic shock. Another one, and this is quite recent one, it's called the reality trial. They found that among patients hospitalized for an acute myocardial infarction, a restrictive transfusion threshold of less or equal to 8 was non-inferior to a liberal threshold of HB of less or equal to 10 for a 30-day major adverse cardiac event. Okay, no difference if the triggering HB value of 8 or 10, no difference in 30 days MACE events. So these are the formulations available in our hospital. We have IV Monofer and also IV Cosmofer, followed by oral. We have 4 choices. I think if you want further information regarding the cost and the frequency of administration, you can always feel free to call the pharmacist up or consult our medical colleagues, as they have an iron suite available for those who have elective patients who are planned for all. I'm already at the end of my presentation. Let me remind that a single donation can save up to 3 lives. And whoever saves life of one person, it is as if he has saved the entire humanity. And I think when the donors donate their blood, they actually give us the amanah. They entrust us with the amanah with their blood. And we have to use it judiciously so that we won't be doing more harm than good to our patients. Okay. And these are my list of references. And we are now already at our question and answer. Again, I would like to remind you, we have our panel of experts here with us. If you have any questions for them, maybe they can shed some light into our questions.
Thank you, Dr. Walina, for your talk. Okay. Right now, we are open the Q&A session. And while waiting, question from our audience for today. My question is that I believe, as you told us before, that 25% in the world population experience anemia. So what's your advice to prevent some of us from developing anemia?
Okay, any of our panel of experts would like to answer that?
Assalamualaikum. Sarah here. Can you hear me? Okay.
Yes,
regarding the question about anemia, it is very common, especially iron deficiency in children, in women of childbearing age. So what we should always advise is to have a proper diet, to have adequate intake of iron in the diet, and especially in children, because we know iron deficiency anemia, it not only interferes with their growth, it also interferes with their learning capabilities. So we should always encourage the children and the women of childbearing age to have high iron diet, iron fortified cereal, and also to seek medical help if they have if they are experiencing menorrhagia or anything like that.
Thank you, Rata. And we'll still open session for our audience. If you would like to interact directly with our speaker today, you may open your microphone.
If I may add to Dr. Sarah's answer, I think also a good way forward is to look into why the patient is anemic in the first place and to treat accordingly, as iron deficiency is very common. If you don't look out for it, you will not find it. So whenever you see an anemic patient, always investigate, because it's not normal to be anemia, to have anemia in the first place.
So we do have one question from our audience today, I believe from Dr. Hikmah. Salam, what is the threshold of the hemoglobin for transfusion in the cases of symptomatic anemia? In our cases, example, in many cases of heavy menses from OMG.
Waalaikumsalam, Dr. Hikmah. So it depends on the patient. So it's a case by case basis. So if this anemia, sometimes patient who has been anemic for quite a long time, they already have they've already sort of tolerated a very low HB amount. So it depends clinically. If you think that the patient is symptomatic and would benefit from the blood transfusion, yes. But as always, we always recommend 1 pint first and see if that alleviates the symptoms. So if the patient is not exsanguinating, I think it's better to have restrictive transfusion strategy. So you transfuse 1 unit first, and then we review back the patient's condition.
Again, if I may add, the usage of IV iron is highly recommended in cases of patients with menorrhagia. Provided the patient doesn't have symptoms of anemia, then maybe we would want to transfuse the patient first. But if the patient is clinically stable and anemic, why not choose IV iron as a modality to increase the patient's HB and red cell mass?
Another question from our participant in the Zoom. Okay, would you advocate parenteral iron for those with ID but not anemic, from Dr. Farid or NG?
For patients who are not anemic but who are iron deficient, in patients who have functional iron deficiency, especially in patients with CKD who are on erythropoietin, there is a role for parental iron. However, if the patient does not have functional iron deficiency, but have iron deficiency but they are not anemic, meaning their iron store is low but not to the extent that they are anemic, I don't think parenteral iron is indicated.
I believe that's all question for today's session. Okay, so again, thank you for our speaker today, and also thank you for the experts for answering our question from our audience. Okay, I would like again to remind the participant to register I attend in I attendance, and for medical practitioner to fill in the Google form through the link given for CPD point. We end our CME today with Tasbih Kafarah and Suratul As. Again, thank you everyone. Assalamualaikum.
Salam,
Thank you
thank
very
you.
much.